Start the meeting.
I believe we are.
Okay. Call the meeting to 4:31 p.m.
Excuse me, wait, yeah, please. Talk in the back. The gavel, please.
Bang the gavel. That gavel. Hard.
We're calling for order.
Already, like five.
Yeah.
All right. May we have roll call, please?
Sure, President Rogers.
Here.
Vice President Rodriguez.
Here.
Secretary Baraza. Here. Director Logston.
Yes.
Director Valara. Here. Director Shore.
Here.
Director Perez. Here.
Will you please join me with the Pledge of Allegiance? Ready, begin. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice. May I have a motion to approve the agenda?
The agenda.
I'll second.
All in favor, please say aye.
Aye.
Opposed, motion carried. This time, we have comments from the audience may be made on items not listed on the agenda that are of public interest and within the subject matter jurisdiction of the district. The board has a policy of limiting speakers to no more than 3 minutes. The board cannot take action on items not listed on the agenda. Public input may be offered on agenda items when they come up for discussion and or action. Are there any public comments at this time?
Public comments for items not listed on the agenda.
Yes.
For items not listed on the agenda.
Yes.
Okay. Please step to the podium. Mr. Lowry.
Goodness, this takes me back to my teaching days. Good afternoon. Easier to begin learning about the district. The gentleman next to me there, thank you, gave me a quick 2-3 minute introduction. It's appreciated. And I'll tell you where my interest became. It is a quarrel I'm having with a council person Downs in Rancho Mirage. I've been here 21 years, reside in Rancho Mirage. He and I have a real disagreement over Eisenhower, Desert Regional, and you folks. And I'm just trying to figure out what the truth really is, where support should be. And this comes out of Measure AA, I believe, right? This issue of no compete. And again, if you want to look up what Downs said, he posted on Rancho Mirage News, June 26th, all of his feelings about Eisenhower, especially. And of course, my contention is Jesus does not live at Eisenhower. Okay. And so it's really caused a conflict. So I've got to learn more and know more. I really don't know what to do. You know, I don't know. If I walk in the street, say hi to the guy at Starbucks and move on. How I want to live. Because I am sick and tired of US News and World Report's rating of Eisenhower. And Newsweek seems to be opposite of that rating. So that pretty much brings discredit to both, doesn't it? That's to me. So I'm trying to figure out where you are when it comes to Desert Regional. Your views on Eisenhower. I know I'm not going to get a straight story on all of this, but I'd like to know why Desert Regional is not more elevated in its prestige. I've been there once or twice, got great service, wonderful. Been to Eisenhower a few times. I consider them the home of ambivalent care. So as you can see, I'm a redheaded Irishman. I'm always ready for a fight. Okay. But Downs especially does things he shouldn't be doing. There are good deeds here all over the place. And those good deeds get covered up by the controversy of no compete. And really, what do you do and how do you service the community? And who does it better? And who has the best thoughts about it? Okay. That's the best I can do here today. So I can only express ignorance, but I'm glad to be here so I can learn. And I don't mind stumbling as I learn. So thank you very much. And I appreciate the work you do as little as I know about it. Thank you. Thank you.
Thank you.
Chris Christensen, I'm the CEO at the Desert Healthcare District. I'd be happy to meet with you at any time.
Thank you
Kind of
very
give you
much.
some overview.
I appreciate it, and you probably haven't mentioned it twice.
And Mr.
No worries.
Lowry, we received your voicemail also. We just received it a little late in the afternoon.
So right in the middle of my sore throat. Thank you so much.
Thank you for
Thank you
your
for coming.
comment. Are there any other public comments? This time? Let's move on to the study session. Study session focusing on the implementation and long-term effects of grant number 1499, Intercare Coachella Valley Teaching Health Center Program. May we have staff report?
Madam Chair,
Yes,
I would like to make a comment first.
okay.
Okay, first of all, I want to disclose that I am on the board of Intercare. I have received notification from our attorney, Judge Scott, that it is okay for me to participate because I have no financial interest in Intercare. So therefore, I will participate in the discussion and in any action that is decided. Okay, thank you.
Thank you. All right, staff report.
I believe, we have the staff report in the packet as well as the grant application, which were all presented at the previous board meeting. You have that available to review or for you to review. I don't know if representatives from Intercare would like to give an overview of the application or how you want to proceed with it. But we've got the information from the Intercare grant application, as well as you're aware, we did engage some services with Germain Solutions to help provide some review and a report to assess their viewpoint on the grant application. So I think it might be beneficial just if Conrado or someone from Intercare would, give a highlight of where we're at today and what progress has been made on the recruitings and, development of the.
Is that okay with the board? All right.
I think I'm happy to provide a brief summary of where we were and where we are today. I'm Conrado Larzaga. I'm the Vice President and Chief Academic Officer for Intercare. This program has been part of Intercare strategic plan for a few years. And in fact, it's very well aligned with the healthcare district strategic plan and also with the assessments that were completed around 2022, the community health needs assessment, the health improvement plan, and then the succeeding assessment that was completed by a Huron consultant, which quantified the gap in access to care, especially in underserved communities. The Huron report highlighted that we have a gap of approximately 200 primary care physicians in the region, and that gap is not expressed equally across the valley. Is a gap that is mostly expressed in underserved communities like the East Coachella Valley and also the northwestern part of the region, like Desert Hot Springs, which we know it's also a desert in healthcare. We also see Cathedral City as another place where there's gaps of access to care. And it's where we have a concentration of populations that are either insured by Medicaid or Medi-Cal or underinsured or uninsured. So we created a plan, and this was, and it is still today, a planning and development grant proposal for the Desert Healthcare District. We invited the district to join forces with Intercare and to participate in the development of the Eastern Riverside Imperial County Collaborative for Medical Education, looking at building a sustainable system to train physicians in our Coachella Valley and to retain those physicians in the Coachella Valley. We hope that by building that residency program, we're going to meet the demand for healthcare, create a stronger healthcare infrastructure, build the workforce that is needed for the region, and have a system that is going to allow access to care for those that are underserved and also reduce disparities in healthcare outcomes as we know exist in the region. At the time that we submitted this proposal, we had a very ambitious timeline. The greatest challenge we have had is recruiting a program director for the family medicine residency program. We continue to face that challenge. We have had candidates that were not meeting the requirements of ACGME. ACGME, which regulates residency programs, have very strict standards who can serve as a program director. We're currently exploring a solution to that problem and anticipate that by the end of the year, we're going to have a program director and that we will be submitting the accreditation application to ACGME and have a program accredited by the summer of 2026. Therefore, we will be recruiting between the summer of 2026 and the summer of 2027 with the goal of starting a residency program in July of 2027. In this year of work that we have been doing, we also receive financial support from HRSA. HRSA selected Inner Care as a site that they want to help develop a rural track so that we can help other communities around the region that require access to care as well. You know, Blythe is probably going to close their hospital soon. We have a situation in Imperial County as well in the rural areas where the lack of physicians is even worse than one we see in the Coachella Valley. And we also receive financial support from Health Career Connections to develop a workforce strategic plan for the region to address the physician shortages, but also to bring a plan to create pathways to other healthcare careers, not only physicians, because we know that physicians don't work in isolation. We need nurses, we need lab technicians, we need X-ray technicians, we need other healthcare careers. So those are the updates that we have in our work. And I want to express our gratitude for what the Desert Healthcare District has been doing. Working with Germain Consultants, it's a great thing. It's really looking with a magnifying glass at our proposal, is looking at places where we can improve. They have identified some areas that we have identified throughout this process as well, because as I mentioned, this is a planning and development grant. So in this planning process, we have found many challenges, some of which we are overcoming, some of which we haven't been able to overcome, but we continue to find ways to address those challenges and carry on, move forward and develop something that the region needs. And that has tremendous community support. Today, we brought 34 letters of support that have been extended on behalf of Inner Care to the healthcare district by our elected officials, by public entities, public health departments, universities, institutions of higher education, other healthcare providers, other residency programs, and many community partners that know the importance of this and that trust Inner Care and BAP Health to create this program. And in closing, this is a partnership that is not only Inner Care, it's a partnership between BAP Health and Inner Care. Is building capacity for the region so that the FQHCs are in charge of their destiny and can train physicians in the setting of a federally qualified health center and retain those physicians in our region. We'll be here. We have a team with us. We have Carmela Meyer, who's our GME consultant. She works for Partners in Medical Education. We have Dr. Wu, who's our Chief Medical Officer. And we have Claudia Galvez, who's our Chief of Community Relations. So thank you very much.
Thank you. Thank you, Carmela. So shall we proceed by going through the application page by page? How do you want to proceed?
I think maybe if there are questions that maybe the board might have about the application that has been submitted and then the update that we just received. If you have questions about that, or if you want us to, go through it, we certainly can. I mean, the ask is for 5.2 million over 3 years to facilitate essentially the staffing of the program from the DIO, program director, other staff, as well as faculty and the actual residents themselves. So want and need more clarity on that, we can. Or we could go to the presentation that Germain Solutions has provided for us to give us some background information from their perspective. And that way you have the opportunity to have heard and reviewed both sides.
I have a suggestion. It's not a strong one. It's a suggestion. Maybe we could go through the application, just review the main points, just as a refresher to the board and then the public as well. And then we'll receive the presentation from Germain, and then that we will be able to reference back to the application if need be.
Can I get, Madam Chair? Can I get clarification from staff? Is the presentation going to include that information already? Is it going to be something that we'll be able to have a good understanding to accomplish what Director Barraza?
I believe it will, because they've looked at the actual application as is, and they're doing some comparisons between what they're seeing and what was actually presented in the application. So I think that would be a good way to move right now, is to do the presentation, and if there's more clarity from the actual application, we can do that.
Is that okay,
Is
Director
that okay with the
Barraza?
board? All right, let's proceed with that.
Okay. So the district has been working with Germain Solutions, Samuel Curan, I hope I've pronounced the name correctly, and Scott Mason. They're extremely knowledgeable, more knowledgeable than any of our staff. That's why we engage their services to help us from the district side to educate the board on what they're seeing, as well as what we're reviewing as a grants team and staff regarding the grant application. So if you gentlemen would introduce yourselves a little bit more, and then we'll turn it over to you to give your presentation.
Absolutely. I'll just go really quickly, then I'll turn it over to you, Sam. But pleasure being with you all tonight. My name is Scott Mason. I'm Senior Manager with Germain Solutions. Our company works all across the country, specifically in graduate medical education. We work kind of all around the different portions of graduate medical education, but one of our strongest areas is creating new programs in the country. And we've created around 10% of all the new programs. It's around like 425 new programs in the last 8 years. So we're really interested. We're really happy to be with you all, and we really want to see more programs across the country, and we just want to make sure that programs that are getting started are sustainable and they can continue to serve your communities for years and years to come. So I'm really honored to be part of this process, and hopefully any of the information we can pass along will just be beneficial to the group and be able to get this program forward to the next steps and accredited by the ACGME. So thank you for your time, and Sam will be kind of leading through some of the presentation tonight.
Yeah, thanks, Scott, and thank you all for having us here tonight. I'll be sharing a few slides, go over this grant, but I'm a consultant here at Germain Solutions. I've been involved with the accreditation and the strategies behind some of these programs in the past. More recently, I've also been involved with some of these California grant opportunities for putting these programs into place. Specifically in the world of primary care. So this is really a field we feel pretty comfortable with. So as I'm going through this presentation today, please feel free to stop me at any point if you have any questions.
And so if I can interrupt, I've worked with Germain before, and it turns out that this grant is a pretty complicated grant, okay? And it has a lot of timing issues, and it's sort of an educational process for all of us. And I just think that I think Dr. Buxton was one that wanted to have a kind of a a meeting where we workshop meeting where we could kind of understand it a little bit better and the process. And these guys are just perfect for that. I think we'll leave here having a much better understanding of this complicated grant and so you can ultimately make informed decisions regarding it.
Thank you, Jeff. Okay, go ahead, please.
Thanks, Jeff. I'll share my screen here. Is everybody able to see it?
Yes.
Perfect.
Yeah.
All right, so I think Scott already gave a pretty good introduction about what we do here at Germain, but just as a refresher on this slide, we have been involved in a lot of areas of GME, starting with the strategy and the feasibility studies behind putting some of these programs into similar facilities such as yourself. We've also done areas of accreditation, so really doing the applications and taking those programs live and getting residents into these hospitals. And then lastly, population health. We've been involved in some grants similar to this one, some of the HRSA grants before, and more specifically, as I was saying earlier, some of those California specific grants that are afforded to health systems in your state. Just before we dive into this further, I just want to kind of bring attention to what the life cycle of starting a program looks like. It always starts with, or at least to some extent, a feasibility study and making sure that all the resources are in place for making sure, a GME program such as a family medicine one is going to be sustainable within a health institution. Typically, this takes about 3 to 4 months, depending on your familiarity with those resources. But from there, and what InterCare has already accomplished as a sponsoring institution is getting accreditation to be able to take the next step, which is to create these programs. So this is called the institutional accreditation phase, which can take anywhere between 3 and 6 months. You can even do it on a shorter time frame if you'd like. But that's already been accomplished by InterCare, so we're really focused on the latter half of this estimated timeline. This next section is really where this grant is focusing in on, which is the program planning and accreditation. This takes about anywhere between 6 to 8 months, starting with the recruitment of not only the program director, but other qualified faculty to lead as program leadership. After faculty are recruited, specifically the program director, oftentimes it takes a few months to get that application drafted up through the review process and submitted to the ACGME. When it's submitted, there's also additional steps that I'll go into on this next slide, but typically there's a bit of a waiting period that's necessary just to make sure all the review done by the accrediting body is fleshed out and ultimately they can make their accreditation decision. After accreditation is received, depending on what time of year it is, you'll hop into the recruitment season, which typically starts in the fall prior to the upcoming academic year, which always starts July 1st. And then lastly, the residence will start, which will be on July 1st of each year. So from the time you start the feasibility assessment to the times that residents start at your institution, this can take anywhere between about 1.5 to 2 years. So for family medicine specifically, the ACGME posts what's known as the agenda close dates and the review committee meeting dates, which are 3 times annually. What the ACGME expects is that the applications are submitted in advance of these agenda close dates, typically within about 3 to 4 months before that agenda close date. And in that time frame of that 3 to 4 months, the ACGME will typically expect that an ACGME field representative will either virtually or in person visit the institution and conduct what's known as a site visit with the program leadership, as well as the institution leadership as well. This is just to make sure that the application matches what the leaders are saying during the site visit and to make sure that everybody is being in full support of this residency program. From there, after the agenda close date and the site visit has been concluded, there is a few months between the agenda close date and that review committee meeting where the application material is packaged up and shipped off before the review committee to meet once they meet in person. About a week or so after that review committee meeting is when they are going to release by email the accreditation decision on whether or not these, in this case, family medicine programs receive their initial accreditation to begin recruiting and then train their residents. So as you can see on the right here, I've created a bit of a table for family medicine submission options. There's the most recent posted agenda close date was on the 7th of August of 2025, which is already passed, but the review committee meeting is going to come up in a few days here. And if you applied within that time frame, you could optimally start a program by 2027. There are two currently scheduled review committee meeting dates on the 30th of January and the 17th of April for next year. If those meetings were met, optimally, those programs could start in 2027 or even potentially 2028, depending on where you lie in the recruitment season after getting accreditation. I listed 3 other dates on this table that are just tentative. Typically, the ACGME won't post them until getting closer to these dates or until the next cycle of dates are posted, but generally they're around the same time frame, so we can expect that they will be around the dates similar to what they were this year. So I just wanted to kind of bring this to a discussion because I know a lot of this slide is or a lot of the information in this grant is pretty dependent on a specific timeline. So I know Dr. Conrado already provided us with a brief update, but when we were reviewing this grant, there was a bit of concern about the potential timeline for getting residents recruited before 2026. So we just wanted to make sure that we're all on the same page for what the status toward the program development was, and what the tentative review committee meeting would be for Intercare to hit in order to get family medicine program accredited and residents recruited.
Got a question for now?
I'm sorry?
Is that a question you want answered right now?
Yeah, I think it would just help continuing further into this I guess thoughts on this grant. It would be useful to know kind of what the tentative review committee meeting or timing of the application is going to be.
Can we get an answer to that?
It's not going to come from us.
It's coming from us. We're planning to submit the accreditation application sometime between November and February so that we will be ready to start the residency program in July of 2027.
Okay, thank you. So if we're looking at a potential start for 2027, there was a packet distributed, I believe, and a part of that packet were 2 separate timelines. One for a 2027 start, which Dr. Conrado had just mentioned. We also put one together for a potential 2028 start, just as another option in case timelines get pushed, either because of resident recruitment or program director recruitment, or making sure that you have all the necessary faculty. But what this kind of looks like, if we're talking about from the start of October this year, is to look towards at getting the program director recruited, as well as some of the faculty identified late this year, early next year, with an application development and submission about March timeframe, which aligns with what Dr. Conrado just said, which would be late February. We're saying early March at the latest for this program application submission. This is because submitting the application requires 3 to 4 months in advance of that agenda close date. And as you can see on this timeline here, I'll just highlight this line that's highlighted, the 7/7 of 2026. You'd need to be submitted 4 months in advance of that. And that's to ensure that you get the ACGME site visit done within this time period, which typically can take about 1 or 2 months to get scheduled and to enact on. Likely get an accreditation decision about 1 to 2 weeks after that meeting date on October of 2026. It's not until you get that accreditation decision, which would be about early November of 2026, that you can really start your recruitment cycle. You're not allowed to be posting anything about the residency program to the public or start the marketing for that program until you have that program ID. You can get started with the marketing, by word of mouth, discussing with some of the, local partners, like, hey, we're in the development of this program, so just be aware if there's any medical schools or students that might be interested, to just keep that in mind, so that once this gets off the ground, as soon as November 1st, when that accreditation hits, you can get into the marketing straight as possible.
Question,
Yes.
if I may.
Mhm.
Dr. Conrado indicated issues related to identifying a program director and suggested that, and that suggests to me that a 90-day timeline for that, plus a 90-day timeline for a coordinator recruitment, might be overly conservative. Now, if I'm right, and there requires an additional timeline, how does that affect the entire timeline of the presentation?
Well, you need to have a program director in order to go through with the application. You can have other
Say it again,
I'm sorry.
you do or do not?
You do or do not.
You do not?
You do need a program director in order to go through with the application.
That's my question. What if there is no program director? How does it affect the entire timeline?
It would ultimately be bumped back. You could have the application drafted and ready to go, but until you have that program director, you are unable to submit.
Okay, and based on what Dr. Conrado is saying, they're nowhere near solving that problem right now, and here we are in close to October, November. So I'd be very concerned about investing in this timeline, sir.
Yeah, and that's also why we created another potential 2028 timeline that can help kind of alleviate the concerns that you might have with the program director recruitment. Similar to the 2027 timeline, you have all the same steps, but you kind of, you're not as narrow on these steps that need to be achieved each quarter in the coming years. You can more focus on that recruitment of the program director, the faculty, the program coordinator, through the first half of next year in 2026, before really get into that program application when you'd be submitting by the end of Q3 of next year.
Did that answer your question?
That didn't answer my question. It just
Okay.
pushed the question away.
Well, I'm just trying to show the
I
options.
understand what you said. Thank you.
Yeah.
I'll try to provide a little bit more context on that. There's some dates that can be pushed and there's some dates that can't. There's the ACGME, the highlighted dates here. Those are published that Sam went through on the previous slide. Those are published for 3 or 4 times a year. And those are set. There's also the recruitment window for the residency program that runs from September to February. You have to have the program accredited before you enter into the recruitment period. So depending upon when you have the right staff hired and when you have the application submitted, there's 4 different timelines that can potentially be entered into depending upon how those stack up against the recruitment window that doesn't shift. It's those same 4 to 6 months every single year. So if you don't have the people in the right positions, you can't submit the application. And say they got the people in the right position in, say, January, February, they could still be on track to start a program in July of 2027. It just really depends on the timing. So, but certainly if you don't have the people in the right roles, you cannot submit the application and it would push back timelines.
Thank you. You just highlighted my concerns, sir.
Yep.
Thank you.
Go ahead.
Any other questions on the timeline before I move forward?
May I ask a question?
Okay.
So the question I have is, so when you're talking about the positions and the faculty that need to be presented as part of the accreditation application with ACGME, does ACGME, do they validate those actual people's names and credentials and that? So that all has to be valid and everything, correct? And I'm not saying anything about this. I'm just, we've had a recent situation with CSUSB where we had, there was some misrepresentation of some of the staffing and that, and so they got their accreditation program rejected.
Yeah.
So I was just wondering how that works, how they validate then all the staffing and the faculty and that they ensure that they're aligned appropriately with the program.
Sure. All the applications are submitted on the ACGME's website through what's known as ADS, which is the accreditation data system. On that system, you upload the faculty's, essentially their CVs manually with their NPI numbers, their board certifications, their previous roles and experiences, committees, scholarly activities, where they did their own residency training and medical school training. So a lot of it is validated through that system, especially for, let's say, the program director who needs to have that experience in a prior GME role, as well as having some of that scholarly activity.
Can I add a clarifying comment? For ACGME also requires that all faculty within the program have board certification. So board certification is verified through their internal system.
Thank you. Any other questions? Okay, go ahead.
Okay, I'm going to move into the program personnel budget. Just so that there's an understanding of this grant about, I believe when the dollars were requested, it was primarily for the personnel salaries and fringe benefits. When we were reading the grant request, we were just, for one, it read as if there were two separate family medicine programs, each 18 residents being established at both Intercare and DAP Health. This was evident through the mention of two separate application processes, one for a residency program that would start in 2026 and one that would start in 2027. In between program years 2 and 3, the PGY1 residents would increase from 6 to 12 residents, having the need for 2 program directors. So we're basing the assumptions of this budget on the fact that the programs are going to be 18 residents each. And the ACGME specifically outlines in their family medicine program requirements what the leaderships are expected to have for protected time to conduct their administrative duties. So below here are the requirements needed for an 18 resident family medicine program. It needs 1 program director who is dedicating 60% of their time to administrative duties in the program. Required 5 core faculty members. This is specifically a 1-to-4 faculty to resident ratio. So they need 5 core faculty members with about 0.3 FTE each core faculty member, so 1.5 total FTE, and then a program coordinator. And they're only required a 0.9 FTE, but simply because that's so close to a full head count, we count it as 1.0 FTE here in the proposed salaries for the program.
And Sam, if I could, just one question that we had in reviewing through this. In the paragraph that you just went through, are those assumptions correct? Are we truly looking at 2 18-person programs here?
Yes, those assumptions are correct.
Okay. So moving forward to the year 1 proposed salaries. So the requested salaries submitted in the grant, they don't currently align with what would be expected under the family medicine ACGME requirements. During year 1, this would be the planning year. So you're assuming a lot of the faculty's time is going towards the program development, maybe a bit of faculty development to prepare for the recruitment season, and then going through a lot of that interview season and getting ramped up for the program by July 1st of the next year. Some of the time would be assumed to be clinical and would likely not fall under the scope of this grant request, which is specifically for the startup of the program. Additionally, we believe that the DIO and the Quality Improvement Officer FTEs are a bit higher than we'd anticipate just based on the roles and responsibilities required by each of those individuals in preparation for the family medicine program. So as it stands right now, this table reflects the year 1 proposed salaries. On the left, we have the positions, and in the next 2 columns, we have the head count and the assumed FTE per one of those individuals. So you only have 1 DIO and 1 quality improvement and patient safety officer. For the FTEs needed for those positions, it's listed as 0.75 and 0.5 each. We just assume this would be a bit higher. We'd expect for the DIO to maybe be spending at max maybe 8 to 10 hours per week focusing on the development of this program through either the recruitment of a program director, recruitment of other faculty members, engaging other. Sorry, I saw a hand go up.
You can, I'll ask it at the end. I just wanted to note I had a question.
Okay. So, and then for the quality improvement patient safety officer, we'd expect about, realistically about 2 to 3 hours per week being involved in residence quality improvement and patient safety events. But this wouldn't even really be until year 2 or 3, but this member does still need to exist and be involved on the graduate medical education committee.
So real quick, just to clarify 2 points. One is you mentioned that there would be some clinical expectations that they would be providing some clinical services as well. Did you mention that? Did I catch that?
Yeah, that was up here at the beginning of this slide. So
Yeah.
the
What would that,
faculty
can you elaborate on that to everybody here what that means?
Yeah, so for the residency programs for the faculty leadership, let's take the program director, for example. They're going to be responsible for administering the program, doing evaluations of the residents, being involved on committees such as the Clinical Competency Committee. They're also involved with the didactics, doing scholarly activity, reporting to GMEC. A lot of that time is involved in about 60%, or at least that's what the ACGME is outlining that they need to protect for those non-clinical duties. And then the other 40% of their time would just be clinical duties, apart from the administration of this residency program. And so as we were working through this and we were seeing, underneath program director and the year one proposed salary, while you do have a headcount and you do have a 1.0 FTE needed, we would assume that this grant request would more likely in this revised salary really only cover that 60% of non-clinical time, because they would still be a clinically active physician in the clinic and not need the additional support from the healthcare district for that salary.
So what type of, I guess the question would go back then, they would need to provide enough patient load to cover that additional 40% that's expected to be met in the salary of that program director, correct? They would need a clinical volume for that.
Correct.
Okay.
And I think in general, the patient volumes are something that we would expect is being looked into. And this is just taking a little higher level for folks in the room with maybe a little bit less experience in graduate medical education. But for family medicine specifically, we're training these residents to become independent practicing physicians upon graduation. So there's inpatient required experience. There's outpatient required experiences that will primarily be provided by the FQHCs that were identified earlier. There's pediatrics experiences, there's adult experiences, really all kinds of different experiences across the board. And for the time where they're rotating through, they need to have patience in order to get the experience. And so I know we're specifically more focusing on the outpatient setting here, but for when the residents are seeing patients in the outpatient setting, these residents are seeing patients under the supervision of a board certified physicians in family medicine, so they can be teaching them, providing feedback, and really getting them to the point of being ready for autonomous practice. But when we're saying here for the program director, they would be 0.6 towards administration of the program. That's non-clinical time, that's working on different accreditation areas. But that other 0.4, they should be in the clinic, they should be working with patients and those types of things. But this isn't necessarily, to host a residency program, you need to have a strong patient population, but this isn't necessarily all additive to what's currently happening in the clinic, because some of the patients who are currently being seen by the current physicians, those will now turn into supervised visits with the residents. But certainly patient volume is very, very important, because residents are not going to get enough experience during the time of training unless there's enough patients for them to see.
So real quick, I'm sorry, Arthur.
No, go ahead.
This is a continual question.
Keep going.
So based on what you viewed here in terms of the amount of residents desired to train, what would be your estimate of an appropriate patient volume that would be required to adequately train them for independent practice?
So there was a rule that the ACGME outlined that it said when a resident graduated, they had to have 1,650 visits by the time they graduated. So that rule was recently taken away by the accrediting body, but it's still upheld by the Family Medicine Board, which obviously is a little just as important as the ACGME. So if we're saying on an annual basis, a clinic that is the continuity clinic for the resident, if we have an 18-person program, they should have six residents per year. If we say 500 visits, that's around 3,000 visits that would need to be at a specific clinic to support the training for those residents. If we have two 18-person programs, that's around 6,000 visits per year. And then give or take a little, that's just some high-level math, but that's assuming also that 100% of the visits in the clinic would be for the residents, but normally there's some independent practice by the supervising physicians alone without the residents. So let's say 3,000 at a clinic just for the residents, plus another 1,000 to 2,000 for independent practice for the physicians without supervising residents.
What about the non-outpatient clinical experience that's required to train family medicine. Can you elaborate on that?
Yeah. So the other biggest, I mean, there's some pediatric experiences that are needed. There needs to be inpatient pediatric experiences that are normally done at either a pediatrics hospital or a hospital that provides pediatric care. The other big one is, well, two big ones. There's inpatient medicine, so like a hospitalist type of experience where they're rotating through and seeing patients in the inpatient setting. There's various kind of requirements for that, but for the most part, we follow some of the different internal medicine requirements. I don't know if it's beneficial to get into all of those details
Yep,
related to
please
ADP.
do. Please do.
So for a teaching team, the average daily census for around 3 residents, we normally see that to be around 15 to 20 patients. So when we're thinking about a hospital specifically, we would have to know the census at that hospital in order to say, does it have adequate volumes in order to support the residents who are training there for that experience? One of the other, and then I guess with that being said, there would be probably 1 to 2 teaching teams for a family medicine program of 18 residents. So when we're thinking about an ADC of a hospital, the inpatient ADC would need to be around 20 to 40 patients in the inpatient setting on the inpatient wards or inpatient teams. The other big one is obstetrics. There's a fair amount of deliveries that are needed. Off the top of my head, Sam, if you remember that, I think it's either 40 or 60, so something like that, as far as the number of deliveries that they have to have by the end of the 3 years. So if we're looking at the number of deliveries on average per year, let's just say 40 for this specific piece of it, it'd be 320 deliveries at that respective hospital. They would have to be dedicated to the residents in order to get experiences before graduation. A myriad of different experiences that are required for the residency program to be successful.
We'll allow public comments after board questions and that. Go ahead.
I have a question. I'm a little confused. I was under the impression that the DIO official and the quality insurance people were full-time employees dedicated to this project. Yet I see they're fractionally allocated to the project, suggesting that they have other duties and responsibilities someplace else outside of this project. And secondarily, if the ACMG doesn't require these roles in specific, why are we spending any time, effort, energy in these positions at all?
The DIO and the Quality Improvement Patient Safety Officer, they are both required by the ACGME and the institutional requirements. Well, for one, they're both members of the GMEC. The DIO is ultimately the leader of the sponsoring institution. The amount of time required for the DIO role, it can depend on the size of the institution and how many programs they're overseeing, how many partners they might have to liaison between for all the different programs. Making sure that rotations are met so that residents have all their experience in line to ensure that they graduate through those established programs. And the quality improvement and patient safety officer, also required by the ACGME and the GMEC as a voting member on their committee, but they're oftentimes just a kind of a connection between the current quality improvement and patient safety initiatives of the hospital or the clinic, and is oftentimes a role that's already hired within that health system, who they just end up taking on maybe an hour or two of their week throughout the year to involve residents in some of what they're currently already working on. Maybe even setting up some individual projects for the residents to be involved for quality improvement. But it's not oftentimes a full-time role that's hired by the health system.
Okay, I interpret that as being either too precise or too imprecise, number one. Number two, it seems that it's all a function of the answer Scott Mason gave as to the capabilities and scope and availability of student experiences, as Dr. Hodgson suggested, making all of this very imprecise and hard to conclude anything from, other than the numbers look impressive.
The numbers look what?
Impressive.
Any other?
Yeah, can you elaborate also, is it a point from you about what are the meeting and didactic requirements outside of the clinical duties that residents have to meet? And how do most programs go about meeting them? What's the requirement of a sponsoring institution to do outside of the clinical duties for the residents?
Yeah, good question. The didactics traditionally are held about a half day per week. That's what normal programs do, is like a Wednesday afternoon. And during those didactics, they're doing different types of lectures that are put on by faculty and or program directors, covering different parts of the body, different organ systems, those types of things. And whether it's kind of actually lectures, kind of like a classroom style, whether that's actually doing some simulation, being able to kind of look at some of those different simulation mannequins, or also you could do simulation as far as simulating patient encounters and those types of things. You could also have some research during times as well, where it's dedicated time to work with the different mentors to work on the research projects that are due upon graduation. So this is really not, as you mentioned, usually a half day per week, and it's organized by the faculty and program director.
How resource intensive is it to develop and maintain the didactics and the requirements for a program of the size that's being proposed?
Yeah. So for the most part, and I think Dr. Conrado mentioned this at the beginning, there's specific requirements around the program director coming in to lead a program. They have to have around 3 years of prior experience within a program. And a lot of the times they're coming in with experience on what's needed for the didactics. They're having kind of an outline of the different areas that they want to cover throughout the year. But you certainly need faculty members, and that's that administrative time that we were outlining earlier, saying that they need time dedicated to help develop the didactic lectures and help really build out these pieces and parts. Because if you have folks that are just all clinically active, some of these things go by the wayside. So it does take a fair amount of work, especially on the front end, to get these up and going. And then on an ongoing basis, you get to update those presentations, update the lectures and those types of things. But on the front end is where a lot of the work goes in to get the information where it needs to be. And the last thing I'll say is normally this is kind of sourced throughout different physicians in the community. It's always great to have, say, a cardiologist come in and talk about cardiology topics, or have a family medicine OB doctor that comes in and talks about different OB topics. It doesn't all have to be provided by the core faculty members, but it is the core faculties and program director that normally provide a majority of the training.
And what happens to programs that don't meet these requirements with the ACGME? What happens to the program, and what impact is it to the residents that are in that program if the sponsoring institution can't meet these requirements?
Yeah. And so the program would get submitted, and then it'll get initial accreditation. Traditionally, about the accrediting body comes back for continued accreditation site visit. From there, there's kind of ongoing monitoring of the program to see how the program's operating. But really, they've gotten rid of a lot of the ongoing monitoring. A lot of the times we see programs getting these targeted site visits if there's complaints in the program from the residents or from the faculty members, low kind of test scores, those types of things. But if one of them, that's when they would come in and do a site visit, specifically investigating the issues that are at hand that they identify either through the complaints or just from the data that's required to be submitted on an annual basis. If they come, you can respond to the site visit, you can respond to some of those citations, you can get those fixed, and the programs, there's not really an issue there. Is the program could lose its accreditation. That's when then the residents would have to be kind of orphaned and sent to other programs to hopefully complete their training. Certainly that's a mess. We wouldn't want to get to that point necessarily, but that is something that does happen, but it's pretty infrequent due to kind of the stringent upfront requirements of the ACGME to try to put folks on the right path and experience of the program directors.
My question is what recommendations do you have to ensure that this would be a successful program? It need more time, obviously need to hire their program director, need to modify their salaries, they need to provide the hospital volume and inpatient volume. Is that all that part of this package?
And then there's one other point, Carol. When it comes to funding of residency programs, how are most residency programs funded ongoing? What's the usual mechanism?
Yeah, the funding mechanism for, I say 90 or more % of all the programs in the country is government. CMS funds the programs, and the funding is routed through hospitals specifically to fund these programs. So not to get
Does
too
that
far.
apply? How does that apply to an FQHC? Is it the same rules, same CMS?
I was just gonna kind of get into the weeds a little bit there. So
You need to stay in the weeds. Yep. Go
yeah,
ahead.
FQHCs are termed non-provider based clinics, and from CMS's point of view, and the funding is traditionally routed to non-provider based clinics through a hospital partnership. And one way that the federal government recognized to say, hey, some FQHCs, they either don't have a partnership with a hospital or they want to kind of develop their own workforce. They develop teaching health center grant funding. And there's two different types of grant funding. There's program development funding, and then there's THC funding, teaching health center graduate medical education funding, where it's actually funding that goes directly to the federally qualified health systems or centers to get the funding for ongoing funding of these programs. The piece that's a little bit difficult right now is the funding for the THC GME program is up for appropriations, and there's a little bit of just inconsistent. And we've actually worked with some programs that were counting on the funding, and the ongoing funding is available. But some folks recently were awarded this, and then they didn't get the appropriated dollars, so they didn't have funding for these programs. So the CMS route, it's more of a guaranteed, for lack of a better words. There's not a pot of money that we're working from. It's just a formula that gets added to the hospital payments. And if there is a hospital partner that would potentially be available to partner with the FQHCs, there's a lot more rules that I won't go into here today, but there are some opportunities where they may be able to claim those residents and pass some of that funding through in order to provide ongoing funding for the program.
How does the political climate today and the inconsistency and uncertainty of the political climate affect the funding of this and any other program related to graduate medical education?
Yeah, if you would guess it, we get that question a lot right now. But for the most part, we haven't seen any specific targets on the GME funding formulas. As I mentioned before, it's not necessarily a chunk of money that we're kind of pulling from a pool. This is all additional or new dollars. If you start a new GME program, it's not getting taken away from someone else. There are goals that have been brought up related to some hospitals that are just working through some loopholes for graduate medical education. But other than that, the traditional funding formula for graduate medical education has not been looked at in more detail, and we don't expect it to change at this point in time.
Thank you.
What was the percentage of programs that are CMS funded? You said 90, how many percent?
The majority.
Over 90%. I mean, I would say maybe closer to 95. The only way that they're funded not out of this is the teaching health center, and then children's hospitals are funded through HRSA as well. But other than those, the main funding is from CMS. And then specific states, as Sam was talking about earlier, there's some other grant funding that may be available through states. And a lot of that is ran through the Medicaid route.
Mm-hmm. So would the
And
ideal
a
way
lot of
to
that's supplementary to the CMS funding.
In your experience, when it comes to opening new programs, how many of these have you opened that have been primarily teaching health center GME funded? In your experience?
Significantly less. And the only reason I may get this number wrong and someone in the room can correct me, there's around like 16 new programs each year that are approved and funded through the teaching health center funding mechanism. But in the same breath, there's a whole lot less federally qualified health centers that are teaching residents compared to the number of hospitals.
All right, back to my question.
Sorry.
Oh, there's who else? Did you have a question? No.
She's gonna take him at the end.
We were gonna take board comments first and then public. So back to my question is that what's a successful formula? We just added funding onto it.
Yeah, the biggest success factor is the program director. They're going to be the ones leading through recruitment. They're going to be the ones who are the face of the program. That's certainly the person who is going to have the best chance to make this program be successful or not. The other one is, as we kind of already talked about, here's the funding. If you don't have a sustainable funding model for these programs, they are rather expensive. I think like on average, we normally see these programs running for about $150,000 to $200,000 per year. So it's not a cheap enterprise to keep running if you don't have sustainable funding from a specific area. The other one is, I guess, just two more. Faculty, you want to participate in this program. If you have folks that are not interested and they're kind of being forced to do so, we see the programs that they don't have the support that they need. Faculty, I mean physicians who are willing to take residents with them and precept them and kind of and teach them. And the last one, the program coordinator, they're kind of they're the coordinator for lack of a better word, but they're the one who keeps everything up for the ACGME, keeps them accredited, submits the documents on time, keeps the for the residents, make sure that they're going where they're supposed to go and document all of that appropriately. So I think staffing is so the folks in those specific roles, very, very important, and funding are two of the biggest areas.
Is inpatient volume and outpatient volume part of the application that needs to be validated as part of the accreditation process?
So there are a fair amount that are required as part of the ACGME application. And so a lot of the times it's one of those applications where they say this is what's required in order to be an approved program. And you have to say, hey, if we're submitting this application and we're not meeting these minimums, we're probably going to have an issue. So we're not familiar with any of those volumes in the inpatient or outpatient settings, but certainly would want to make sure that those are patients so they wouldn't have any issues.
Go ahead.
Dr. Conrado, how long have you been looking for a program director?
Since February of 2025.
Since February of 2025. So that's what, 10 months?
Yes.
8 months? And okay, thank you.
Welcome. I would like to address two topics about volume and about funding.
We'll get to you, Dr. Conrado. I just want to finish with board comments and then we'll call on you next. Are there any other board comments?
I have comments, but I would like to hear from Dr. Barraza.
All right, okay. Dr. Conrado, you're on.
Dr. Wu was our chief medical officer. We can talk about the volumes that we have at InterCare.
We do have a 3-minute time limit, but we're willing to extend it a little bit.
Sure.
President Roger, you can come to the podium, please.
Please.
Thank you.
But do we take his comments as public comments or answering? I don't think that we should limit it to 3 minutes if it's us asking questions.
There are public comments, these are sometimes answered.
So in terms of deliveries, we do 2,500 deliveries through Pioneers. 2,500 deliveries through Pioneers Memorial in Imperial County. Imperial County only has one delivering hospital, that is Pioneers. ECRMC had shut down their services. And so the majority of our faculty is there, but we also have the ability to also deliver in ECRMs into Eisenhower Medical Center as well. We are composed of 10 clinics over 2 counties. Okay, 10 clinics over 2 counties. And the volume is fairly significant. We have a long-standing obstetrical program that has been in existence for over 60 years. Same thing with family medicine. And we did have a time in which we had not one, but 3 residency and fellowship programs that were coming in for experience. And we thought that was going to be too many people, but it turned out we didn't have enough to cover everything that was happening, both in the hospital and the clinics. So we know in terms of volume, we have a very high number of visitations in the clinic, and also a number of deliveries that are scattered throughout both counties. So I'm, as somebody who has been observing this firsthand on the ground, watching the current residents and fellows come in, I know that we have more work, more patients, and more pathology to deal with than the residents that we possibly have from even 3 programs. In terms of family medicine, I can't speak in the best detail from that, but give me just a minute and I will get the exact number of visitations we at least have on an outpatient basis. Let me just text a couple people and I'll get you that number in a minute. Any other questions?
Any other questions?
Do you have any sense of the number of residents that continue on in our global communities as a result of the program?
That's a very good question. I'm glad you asked that. I can tell you that the fellows in from Scripps Family Medicine OB Fellowship, the ones that had rotated through InterCare, about a little over 50% still retain interest in wanting to be able to do deliveries with us and inquiring about a job as well. So a little over 50%, and I was surprised by that number as well. And what is also very interesting is that some of these individuals have gone off to become program directors for obstetrical programs around Southern California and San Diego, and they actually have been coming back to us to ask us to further educate their residents. So it has a snowballing effect. You're right. And I think that it's what you put into it. If you give good training to people and you show them that you care about their education and care about them as an individual, they will want to stay. But more important than that, I think what's very difficult and what kills me every time, and I think probably Dr. Logsdon talked about it too, the world doesn't really know how great it is out here. We have 2 fantastic institutions, Desert Regional and Eisenhower. And there is the rest of the application pool in the world that doesn't have a clue. They think that Eisenhower is some rinky-dink hospital that is undercapitalized and ill-capable of taking care of advanced patients. I myself was shocked. I will tell you that when I went down to Pioneers initially, I did not know what kind of building or what kind of facility they would have, but I thought to myself, it's got to be a small place. It's a rural setting. This is a building that was built in architectural cladding, and it is actually a very nice building. And if you saw the labor and delivery, you would see that place is built for volume. It is a significant maternity service, very well capitalized and very well infrastructure. And when the residents and the fellows from San Diego came over to Pioneers, they were shocked. We are doing volume and complexity of patients much higher than San Diego. And whether we like it or not, the truth of the matter is, if services shut down east of us or south of us, everything's going to come back into us here. And we need to be ready for that. Because I could tell you what I dealt with in about 4 years ago when ECRMC shut down their services. It is tough just absorbing 1,000 new deliveries. It is really tough. And it is a nightmare for all of the physicians and the infrastructure that is within the hospital. It is really tough. And we can't do that with the current set of physicians. I'm telling you right now, we are down 5 OBGYNs on our service for the 2 counties, the one down south, actually. And then we're going to lose another 3 from retirement One of them just threw his knee out, the other one's physician isn't gonna let him take call again. So we're gonna be down 8 OBGYN physicians. And if you saw the Beaker's report, the highest attrition in all of the specialties that you see, okay, are OBGYN, family medicine in rural settings. And that's the reason why we really need to wake up and realize that this can potentially be the godsend, the gift that we're given to fix a lot of our problems. But let me get those stats for you. Yes.
So,
Go ahead.
so first of all, I thank you, Dr. Wu. I do want to start off my comments by saying is that when you say about what great institutions we have here, yeah, we have some pretty good ones, but I know that if I have a family member that requires specialty care, I'm going to be looking to LA or San Diego because that's the reality. And unless we start doing things here today, we're always going to be doing that. And there's a lot of families that do not have the resources to look to LA or San Diego. So we need to work sure that we have that specialty care here. So that's my first comment. So I know I'm kind of jumping a little bit ahead here, but so far I've learned a lot tonight. So, and I'm sure I need to learn a lot more. But as I'm looking at the staff report and the grants funds are contingent upon, I'm just wondering who put these contingencies in? Was this with the expertise of Jermaine Strategy? Was it with their expertise? Because I get so far what I'm learning here tonight, I get number 1 and number 2, but number 3, the legal review and approval and affiliation template, is that something that they are also thinking that is important for us to include as a contingency issue? And also number 4, that it be on a reimbursement basis. Is that something that they are also recommending? So I'm just curious, how did this come about?
Yeah, we talked about this a few months ago. And those went through committee and they came to the board.
So
those were things that we worked out with.
So it has been with them and
With
they're
Intercare.
saying these are.
No, we worked those issues that you see in the staff report. We talked about those with Intercare, okay? And then we brought all this to the board. And then the doctor said, hey, wait a minute, we need to have a workshop so that we understand this better.
Okay.
So that's what Jermaine's in, and they're kind of going over, and it's kind of think it helps all of us to understand what the grant's about and really in a real workshop setting. But yeah, that to answer your question, we've been over.
So again, just to clarify, this is something that Jermaine is confirming that are reasonable requirements.
I don't think we've asked him to do that. This may change by the time we get done with the workshops, whatever the contingencies are and the timeline goals and the amounts, those are things that you're going to talk about tonight. So those contingencies those are things we discussed a few months ago. And really, I think for tonight, we need to kind of understand the process, the timeline, and how much is being funded for what. So that's kind of where
Okay.
that's why this is a
I
workshop.
was jumping ahead, so thank you for that clarification. Thank you.
Are you done?
I'm done. I passed up the mic.
Any more questions for Dr.? Okay.
How many people from the Coachella Valley are being seen at Pioneers?
Students.
Do you have a number of patients?
Yeah, that's a very good and interesting question, because one of the gray areas is actually the Salton City area and West Shores. We have a clinic there. And so usually that falls into an issue or category with which insurance they have. So if it's CHPIV, usually they'll go down south. But if it's IHP, they'll be going up north. And we do cover those patients. I don't have the exact number, but I can.
I would like to know how many of our,
They're not gonna know. How many from our district go down to the Imperial Valley District to get care? This Pioneers is in Imperial, right, healthcare district. Would you, this is question. Would you expect a lot of this training to occur down at Pioneers, you think?
That's a good question. And I think the reality is we're going to have to distribute it across the hospitals, including Eisenhower.
What would that mean with the already existing residency programs out here? And then what would it mean for the residents in terms of, where they're going to be working every day or month? And there's a whole lot that comes with expecting them to, Pioneers isn't exactly close to here. It's definitely not close to Eisenhower. Both Eisenhower and Desert have their own individual training programs. I don't know, there's gonna be a lot of things to work out. It's gonna be kind of complicated, I think. Just from me looking, having gone through it and from the outside, I think your points about need are there, but your points about the fact that your OBGYN physicians are retiring, I just get concerned about who's gonna train these residents. I mean, these are not, I don't think the board here knows, but residents aren't there to labor. They are there to learn. And the problem with a lot of the training programs is that they are viewed as affordable labor for hospitals when they're supposed to be there to learn. And so what you get is you get a bunch of busy training residents that are very good at working in the computer system, but when it comes to actually being educated on the clinical side of medicine, they're not. And then you see these residents that are not passing their boards successfully. They end up being, non-board certified physicians. There's a lot of, my biggest concern is that there's a lot of responsibility that comes with being a sponsoring institution, because you're taking somebody who may have had $300,000 or $400,000 in debt, and you're saying, hey, come with us. We have everything you need to take you in 3 years from being a medical student to an independent practicing physician that I would send my loved one to. And that responsibility is very challenging to do successfully. And so I think you have to be very cautious as you step into this about how much you actually think you can do. Because it's not just, do I have faculty that can train them and meet the didactics? Do I have the right patient experience? And what is it going to take for me to see these patients? What is it going to take to get them exposed to everything, to educate them, especially when we already have competing residency programs that are already being challenged to meet their patient load requirements. And it's a little concerning to me, and I didn't know ACGME removed their patient load requirements, but I'll tell you, probably the reason why is because they need more physicians approved to get through the process. They're not really care. If you cared that they were trained, you wouldn't cut your training requirements, right? But as a group, we should care about how many patients they're seeing and that they're becoming well-trained, because somebody has spent $300,000 or $400,000 of the money. I said that already. And they need to come out and be practicing successful physicians. If not, then we have not done any service to anybody.
If I can answer.
Yeah, go right ahead.
I totally agree with you. And I understand that sentiment and totally agree with what you're saying. The issue of, yes, making sure that we have a meaningful education for these residents is critical, because it's not just about throwing in a warm body to address healthcare. It's about having somebody who's competent and hireable, somebody that we can hire to develop the talent to stay in the area. So all of our faculty were very keen on that ability to generate our own talent to have and disperse throughout Coachella Valley and Imperial. I do want to caution everyone here. When I did say 5 OBGYNs that left already, that had occurred over the last 7 years, and they.
The point's well taken, though.
The 3 other that are decommissioning themselves, only one of them is ours, and he is 70 years of age, so it's understandable. But the rest of the core of us, faculty, we will be there, and we are desperately wanting to be able to have this residency program to be able to help us with the bandwidth and help us to recruit more talent. The other issue about what was the first issue that you talked about, Letty? It was
Well, I was just being told about certain things that have happened before, which I haven't been part of those
Right.
conversations because I was keeping myself away from it. So that's why I wasn't familiar with those things, but I was asking about the contingencies that they were inquiring because of I just want to make sure that they were reasonable, so.
Yeah, I think in fact, we offer those contingencies.
Okay, thanks.
So that the district has the confidence that they're not going to spend money in a wasteful manner. That whatever monies are spent is based on performance by Intercare. So we won't get any funding unless we get a program director, unless we get into an accreditation process, unless we've hired the faculty. That's why everything is on a reimbursement basis, so that the district wouldn't spend a dollar that is on a pie in the sky. It's based on the facts and things that are happening on the ground.
Yeah,
And my question-
sorry, the other comment that I wanted to make really quickly was that, yes, we don't have a family medicine program director yet. We do have several in the pipeline that we are interviewing and going through their CVs and actively interviewing and recruiting. I will tell you that Dr. Barzaga and I have we have a good working relationship, but Dr. Barzaga is very careful in picking who the program director is going to be. And so there were several in which I was just like, well, this looks pretty good. We should just hire them. But he has gone through these resumes very carefully. And the fact that we are being very careful about who we pick to set us up for success tells you part of some of my honest frustration with Dr. Barzaga, but it is an honest process that we have to go through to be successful.
Thank you. I had a question for Jeff. The grant funds for this program are for residency training program. I think they said 10 clinics in 2 counties. Is it legal for us to fund services outside our service area?
No, we've been very careful. That's why there are these 2 programs. We've worked with Intercare to be very careful to make sure that the residency programs is going to be that the district is supporting is going to be within our jurisdiction here. Okay, so that's not an issue. I do think, and I know that Kimberly has a question, but there are some more for Scott and Sam. There's some more, I think, education here that we can kind of work through if we let them get through their presentation. And certainly as we go along, we can stop and have some comments as they come up. So if you're finished, do we have the next person take the podium?
And I think Jeff's suggestion is good.
Kimberly's question, and I have a question.
So actually,
Okay.
I would like to know, because I know that I believe that they have some answers to their concern, which I would like to hear. We're using this as a midpoint. I would like to hear from them. That way we don't forget about that before we move forward.
Yeah, I think we were gonna call the next speaker card or.
Can I just,
We on public comment yet? That's what, or.
no, we're just, this is a workshop. We're just, we can call on there, then, and and the board should have priority, but we can work together. This is a workshop.
All right,
Scott, I have a question, and please don't mistake the purpose of my question, but respect it. How many programs have attempted to succeed and got full accreditation and failed in the last 5 years that you know of?
I can try, I actually pull up the number of programs that withdrew accreditation. So I'll get that number.
Just an order of magnitude. I'm not looking for a number.
Less than 10.
Thank you.
thank you.
Less than 10% or less than 10 net total out of how many?
I would say less than 10 family medicine programs have failed in the last couple of years. I'll get you the exact number here.
Thank you.
Next person.
So
Hi. Good evening, everybody. Some of you I've met, for those I haven't, my name is Karina Velasquez and I am the acting chief operating officer for DAP Health. I am a Coachella Valley native. Grown up in Coachella and currently reside in Indio, and I have for the last approximately 20 years dedicated my career to expanding access to healthcare in the Coachella Valley. I want to say that it is widely known that those doctors who practice their residency, where they practice that, they're 2 to 3 times more likely to stay. That's just another driving home point of why this program is so crucial. I want to give, since the question was asked, I was eagerly texting my team for some stats for you all, but as part of DAP Health and for those within the Coachella Valley, some of you may not know, we have clinics in Riverside County, Coachella Valley, as well as San Diego. But specifically for the Coachella Valley, we are averaging 5 months, we ran the last 3 months, about 11,500 visits in the Coachella Valley alone. Just to give you some context, and I will tell you that just as everyone is feeling it nationwide, FQHCs are feeling it especially harder in terms of the clinician shortage. It takes so long to find a clinician, specifically when you're trying to find them to come to the Coachella Valley. As Dr. Wu mentioned, they don't know how great it is out here. They just haven't been here. They have no concept of what's going on. We have had the privilege of hiring some clinicians who were from the Valley, left to get their degree and have eagerly sought to come back. We just hired a dentist in our Coachella Valley clinic. Patients love her and she's so happy and wants to be here. She's a very young dentist. Same with some of our other clinicians. We need to build programs like this. And while I understand that timelines and grants and all of those are also an area of concern, I do want to stress to the board that inaction just means further delaying the access that our communities and our families and friends and neighbors need. It's right now our next available appointment, which is an operational metric we use to measure access. Our third next available can be anywhere from 30, sometimes to 60 days out. And that's with trying to put out for per diems. We pull in locums if someone goes on leave. We're doing everything we can, but trying to home grow our own, I think, is a very unique way for us to build the infrastructure that this community so desperately needs. Any questions for DAP? We will be here in case they do come up. Thank you so much for your time.
Thank you, Corina. And I want to talk about volume again, because that is a question that comes up. In our Coachella clinic, our number of visits is about 6,000 visits per year. And our Mecca clinic is about 4,000 visits per year. So between those two alone is 10,000 visits per year. So we have the volume. And, you know, as we were going through this process, we invited Jermaine to come and do a site visit so that they could learn on the ground from what we're doing. I'm sure they didn't know that we delivered over 2,000 babies every year. So
Pioneer does. Pioneer does.
So
In
Intercare,
Imperial County delivers.
So- Intercare delivers, so Pioneers delivers a total of around 2,500. I think we delivered somewhere around over 1,700. Intercare, we,
Here in the Coachella Valley
not in the Coachella Valley, but in
Pioneer?
Imperial.
Pioneer.
Yeah. And the other thing too is that the difficulty right now is that Eisenhower does not have an OBGYN program. Okay.
Training
They're
program.
correct. They don't have an OBGYN training program, and they manage most of their deliveries through a OB hospitals group. And one of the problems is that for us as an institution to put all the deliveries in just one place, we're probably going to have to distribute through the different programs. But we are going to have to be able to help out Eisenhower as well with their deliveries. And so when you ask about volume, okay, you take into consideration the potential volume that can happen for Eisenhower. So we basically have a very open and furtive place in Eisenhower as well for potential deliveries. And the future of covering those deliveries, I think, would be challenging if we don't have something like a residency program to help them.
So thank you, Dr. Wu. The next point is about funding. And yes, the mechanism for supporting teaching health centers is different than the traditional funding mechanism for hospitals. Therefore, the Affordable Care Act created the teaching health center mechanism that is funded through Congress. So it requires appropriation every so number of years. And right now we know what's happening in Washington with the government shutdown. So we're not sitting down and waiting for the teaching health center to become the funding mechanism for us, although eventually it may become that. We also want to highlight that the state of California has two programs to support residency program, the Son Brown program and the CalMet program. So those are two specific to California programs that are funding GME in our state. And my final comment about funding is, yes, this is not easy. What we're doing is something that is very, very challenging. You may even call it risky. But if we don't do it, if we don't try it, what is going to happen to our community if we are not willing to invest and to try and to create residency programs that are homegrown and that are going to provide the residents and the graduates that we want to retain in Coachella Valley?
He talked in reference to Song Brown. Have you guys applied for that? I mean, we did. Grossmont got, I think, $4 million last year just for that.
Yeah, we applied for the cycle. Yeah.
Okay.
Just a couple questions, if you don't mind taking, can you take questions? Is that okay? Yeah. Why, if you have two successful residency programs here, why try to start a third one that has a very complicated funding mechanism? You already have family medicine programs here, internal medicine programs.
They're capped. They can't add any.
What do you mean?
Eisenhower and Desert cannot increase their GME programs. They're capped by CMS.
So yes, that's the number one limitation. Thank you, Dr. Sandy.
On every program?
Yes. Another residency program.
Because of volume?
Capped at the
But why don't you get sponsored by one of them? I mean, there's UCLA's program's massive. They send you out to everywhere. Scripps sends you out here to get trained. Why not look at something like that and use some of the already internal mechanisms? Because the hard part of a residency program isn't always the clinical side. It's everything you have to do and all the people required to keep your accreditation, keep your didactics. We've got two of those things here. Why not look at something like that?
Can I answer that?
Yeah, sure. Go ahead.
The reason you don't is because the purpose.
Can you stand and state your name?
Yeah, I'm Dr. Carmela Meyer. So the reason you don't do that, the purpose of this is to recruit and encourage residents to recruit. Those stats that have been talked about is increasing likelihood that you will retain your GME residents is only if it's your program. If it's just a rotation, so for example, if we were to do a rotation for UCLA, for example, which is a great program, very successful, and let's say we just did a rotation, that is not going to encourage retention here in this community. And the point of building our own residency program here is to retain, to recruit our own physicians to stay in this community. And those additional increases in the retention are only for if they do their residency program.
So real quick on the match. So when it comes to getting residents here, I'm not sure how many people are familiar with the match, but it is very, very random, you know, in terms of where you get. So just so you're also aware that while a lot of people may stay where they train, they're not going to be from here. You can't individually select people from here. Now, you can offer interviews and things, but there's no guarantee those people are anywhere around here. A lot of them may be foreign medical graduates, which is very common at Eisenhower now. You know, you're getting them finishing medical school somewhere else, coming in as IMGs, international graduates. So
that is, go ahead, Carmela.
So, but in order, because we're being recorded, you know, you need to be in front of the camera. for the public record. Sorry.
It's okay.
So let's wait for Dr. Lofton because
Okay.
he needs to hear it.
Pretty cool.
You got a call.
Oh.
Yeah, do we need a short break?
Yeah, I'm gonna go with or without your permission.
Would you mind if we had a few minute break and then come back? That work for you? Carol? Yeah,
Are they finished?
I'm sorry.
No, we need to finish their presentation, just like we started it. We need to go through their presentation.
Oh, they're not done?
Oh, no.
Oh.
They didn't stop.
Oh, I'm
In the
sorry.
beginning.
I thought they were completed.
No, absolutely not. There's no.
Okay, well, let's, we just need a 5 minute break. It's called 83-year flat.
Oh. You broke it into two sections.
Yeah.
Sam, I'm gonna do this for a moment, okay?
I don't know this.
We'll be right back.
I have some. Oh. Like, yes.
Scott and Sam, if you understand, we're gonna just take a 5 minute break.
Okay.
I'm just gonna mute her.
We're trying to adjourn. So we're gonna allow Dr. Conrado, Dr. Carmella to finish their point. And because Dr. Watson has to leave, the plan is to reconvene the study session so that we can finish the Germain presentation at a later date, hopefully very soon. You're on.
So I wanted to address Dr. Longston's questions about the match. So one of the trends that we are seeing, and I guess we lost Scott and Sam, but one of the things that we're seeing in medical education right now is that medical schools are increasing their class sizes significantly across the country. The other thing that is happening is DO schools are popping up left and right. I mean, they are increasing exponentially for a number of reasons, but it's about 2 or 3 notices that I'm getting a month about a new medical school, DO school being planned. So saying all of this has to do with ACGME. It's not that there's not enough medical student slots to fill the severe shortages of physicians in the country. The bottleneck really is residency programs. And the ACGME is beginning to recognize that. And so they don't want to close programs. They're going to do everything in their power to help programs be successful, especially in areas that are medically underserved. So what is happening with this huge influx of medical students is that, one, the J1s are getting pushed out, not completely. I'm not saying that at all, because there's still a significant number, but there are not enough current residency programs to accommodate the current graduating classes of medical students. And so that's why ACGME, they will shut down programs. And Scott, I think you looked up that number. It is about 10 that have been closed. They have been known to close programs, but it's egregious. And so what happens is they come in and do a site visit and they see, okay, you've got some concerns here, major concerns. Little blips are just going to be citations. They're not going to change your accreditation status for that. But the first kind of significant, they say, okay, we're going to give you a hand slap. They put you on warning. And basically what warning says is, we see some major concerns. We want to give you time to fix it. They usually give you about a year, and then they come back and they tell you exactly what needs to be fixed. So it's not like a guessing game. And then they come back a year later and they reevaluate. And if you fixed it, they take you off warning. But let's say they're still concerned. What they do next is they say, okay, you still haven't fixed this. You haven't taken us seriously, because it really does take making no change. They put you on probation. That's the next step. They put you on probation for usually a year to a year and a half. Again, they tell you exactly what you need to do to fix the program to move back to continued accreditation. They come back after a year to a year and a half. If they don't see change, you get a second probation. Again, you get a year to a year and a half to fix the program, at which time, if it's not fixed, you really have to just really not want to fix the program at that point. But that's the point when they say, okay, no, we're not going to move forward with this. But some of the things that are causing programs to get shut down, I can tell you from experience some of the things that I've seen. One was a program in New York. A surgery resident, a second-year surgery resident, was in the operating room performing surgery without any supervising attending anywhere in the facility. That program was closed, but it should have been closed. I've seen also programs with up to 32 citations. They get put on probation, but the ACGME works with them to get them off probation, resolve their citations so they can continue. I'm not saying there's absolutely no risk. Like Dr. Barzarga has said, is this isn't easy. I mean, the other way to say it is, for a few of the doctors in the room, this ain't for the faint of heart. It is a challenging endeavor. There is risk. There's a risk with everything. But my question is, yes, there is risk with this. But if we don't do it, we know what will happen. And so that is what you're balancing. It's not balancing yes or no, you want to take risk. It's yes or no, do you want to be here 2-3 years down the road and still not have the physicians that you need and have lost life because of it. And that's kind of where the community is. That's what Letty, you were talking about with having to go to San Diego and Los Angeles. Well, yes, it's wonderful, but how many of our community members here, and I do feel like I'm part of the community now after being here for 2 years, but how many of them can't do that? And that's what we're talking about. We're talking about building a healthcare structure to support the community so that you're not here in 2, 3, and 4 years.
So a final note on recruitment. You mentioned, Dr. Luxton, that you had questions about recruitment. We cannot rely only on match. We need to work on a pipeline, and the district is investing in a pipeline here in the Coachella Valley, right? You're investing in One Future Coachella Valley that is holding hands and taking students through that pipeline, making sure that they graduate from a medical school, and those students are from the Coachella Valley and they want to find a place where they can match and they can do the residency program. In addition to that, InnerCare is working with a medical school. I can't disclose which one, but we're working with a medical school to make sure that we have a medical school here in the Coachella Valley where students are completing their clinical training. And this is a model that has been tested and has proven to be successful in other FQHCs, and San Isidro Health Center in San Diego is one of them that you can look at. They have built a UME GME continuum. UME is undergraduate medical education and graduate medical education. You have a medical school that is training their physicians in an FQHC environment. And when they graduate, they participate in that residency program. So you have that continuum in addition to the other efforts that are undertaking in the Coachella Valley with the support of the healthcare district. We're also working with other medical schools. We partner with UCSD. We have a medical scholars program. We also partner with UCR. So there are many medical schools that are already sending students to complete internships with the FQHCs in the area, with DVP Health and with InnerCare. And those are the perfect candidates to find a residency spot in our clinics and completing the residency program. Thank you.
Thank you so much, Dr. Ferrada. I understand. Go ahead.
Concerning the accreditations, Scott, you want to mention what you put in the chat?
Yeah, I just wanted to say that I confirmed those numbers. It was 9 programs had their accreditation withdrawn in the last 5 years for family medicine.
Out of how many?
Out of how many?
Nine.
No.
Hundreds, thousands?
Yeah, more than
Thousands.
Okay, 10%.
It's no, it's less than that.
1%.
Yeah, maybe 1%.
1%, okay.
It should be pretty rare.
Yes,
So-
it is rare.
Dr. Logston has to excuse himself, but conversation is to reschedule this study
Continue.
session for another time. we convene.
President Rogers, we have a public, we have speaker cards here. Speaker cards. I mean, we have to call for public comment.
How shall we proceed?
We should proceed with the public comment before we
Without
adjourn.
Dr. Logston?
Well,
I'm sorry? Just to have quorum.
I think what we should do is allow just a quick public comment on this. And then we'll reschedule this meeting and you know, doctor, if you have to go, you gotta go.
And those we'll have more public comments at our next study session. Okay.
Okay,
Yes.
you too. Dr. Linville, please, would you come to the podium? Thank you. Please. Up with any other public comment?
This side.
Anyway, many of you know that I was on the district for 8 years. But also, many of you don't know that when I was associate medical director of Kaiser Southern California, we had 450 GME residency slots in Southern California, and they fell under my purview. So we've had a lot of experience. Kaiser did that because that's how you recruit doctors. Eisenhower is doing it because that's how you recruit doctors. Desert is doing it because that's how you recruit doctors. But Desert and Eisenhower are capped. They probably would like to have more because it's funding that's associated with it. But the other problem that Desert and Eisenhower have is they don't have outpatient facilities because, especially in primary care, most of the care isn't delivered in hospitals anymore. It's delivered as outpatient. And you've got to have outpatient training. And especially here in the Coachella Valley, we want to make sure that that training is done in places that they can learn culturally competent care and understand what's really going on in the community, not necessarily in the high volume, high resource communities there are. I'm generally supportive of the InterCare effort to have a teaching health center. I think it's a good idea. I think that there are HRSA funds available. They're not going to come from CMS and the Medicare funding that funds hospitals, but it can come to fund family health clinics, FQHCs, along with state funds probably. I also think nobody can question that there's a need, that we need more doctors here. And this is one way that it can be addressed. We're addressing it in other ways, but you need to have graduate programs to do that. I really defer to the staff and to the district board as to deal with the appropriate timeline issues and budget issues that Germain Solutions pointed out. I think they do need to be addressed, but I think they are being addressed. Some of the people have raised issues about, well, can it be accredited? Are they going to have trouble recruiting good students? Are they going to stay? Well, we don't know all the answers to that. And that's one reason I view this less as a grant to do a program, but more as a demonstration project or a research project. Because although there have been FQHCs that have had residency programs, they're not exactly the same setting as the Coachella Valley, where you have a big area, where you have a big disparity in the same area between people that are getting more care than they probably need and people getting less care than they need. So I really do hope that the district will continue to work with InterCare to work out the timing issues and the budget issues. But I really hope that they will proceed with pushing the program forward, the project forward, because I think it's important. And yes, I know.
Thank you.
Boy, I've always wanted to get the 3 minutes on you.
Anybody else, Andrea?
I believe so. Is there anyone else online that has public comment? I don't think so. Anyone?
May I have a motion to adjourn?
One thing before we go, there was an additional comment about the question that we keep returning to. The total number was, I think, 1,228. That's the.
Yes, let me pull that up.
It's 1,220 programs, family medicine programs in the country, and 10 have been closed in the last 5 years. So it's less than 1%.
Good to know. Thank you.
We'll be in touch with you, Scott and Sam. Thanks so much.
Thanks, Scott. It was excellent, by the way.
Thank you.
Thank you all.
Thank you. Thank you.